Karibu tena mtazamaji, unaendelea kutazama taarifa za NTV Weekendi. Na huku mfumo wa mamlaka ya afya ya jamii ya SHA ukiendelea kukita mizizi, serikali ya Kenya kwanza inawania kupata bima ya afya kwa wote, ukipenda UHC, kupitia mfumo huo. Lakini NTV ilizungumza na Katibu wa Afya Harry Kimtai akifafanua bima hii ya SHA na mkondo unaostahili kuchukua, mbali na changamoto ambazo tayari wa Kenya wameshuhudia. Alizungumza na mwanahabari wetu Helena Aura. Taarifa ndio hii.
Miezi mitatu sasa tangu bima ya SHA kutekelezwa, na Wakenya bado wamejawa na maswali. Chini ya bima ya NHIF, Wakenya walikuwa wanatoa shilingi 1200 ili kupata huduma za afya kwa matibabu na kuruhusiwa kwenda nyumbani. Ila sasa chini ya SHA wanalipa shilingi 900. Je, pesa hizi zinatumika vipi na kuhakikisha Wakenya watapata huduma mwafaka?
The contributions where we pay 900 is basically the capitation fee that we pay to the facilities. And these facilities are categorized. They're categorized into 2 levels, which is level 2 and level 3. How they are supposed to offer service is based on the capitation, the number of population that visit that facility, times the 900 shillings that they are supposed to pay. And then that is remitted to them on a quarterly basis. So they are supposed to treat the patients free, because level 2 and level 3, it is free primary health care services that we offer at those levels. So this we assume will be able to suffice for those levels. We also did open this to level 4 because we realized that some of the populations where the level 2 and level 3 are is a bit far. So we elected some of the level 4s to also offer such kind of services where it is capitated. So that's on capitation. So we believe that is sufficient enough because it is dealing with the minor ailments.
SHA imerekodi changamoto kadhaa kufikia sasa, huku Wakenya wakisema hawawezi pata huduma zote wanapokwenda hospitalini, na hospitali zingine zikisema bado hazijakubaliwa kutoa huduma zote chini ya mfumo huo. Je, mfumo huu uliharakishwa?
No, it's not been rushed. We just faced challenges. We realized there was no proper legal framework, because we're using the old. The way NHIF was delivering, and you want to deliver social health, universal health care, it was impossible.
Huku zaidi ya Wakenya milioni 15 wakisajiliwa chini ya mfumo huu, SHA imepata pesa ngapi kufikia sasa?
For the first month, we collected about 6.4 billion. The second month, it slightly dropped to about, I think it's about 5.3 billion Kenya shillings. We also want to encourage Kenyans to pay. Maybe they paid the first month, they have not paid their second month, all right? Because we told them pay monthly for the time being. You know, we want those who are unemployed to pay the entire amount upfront. But again, we faced, there was a lot of hue and cry. Kenyans were saying, why do you want me to pay everything at a go? So we've opened up for them for a period of, we agreed for a period of 3 or 4 months as we develop what's called the insurance premium financing.
Hospitali zimeilaumu SHA kutolipa deni, huku zingine sasa zikisema deni hilo linazuia utendakazi kwa Wakenya. Je, pesa hizi zimelipwa?
2.1 billion, yeah, of which we have paid. The second month was another, I think they're telling me they're still doing, they have paid 1.1 billion.
And the issue is,
aliyekuwa naibu rais Rigathi Gachagua alisema mfumo huu wa SHA umewalaghai wa Kenya. Je, ni kweli?
experts have told me that it was possible to improve the existing system that was in NHIF at a cost of between 700 to 800 million. Here we are spending over 100 billion. And from where I sit, when I look at the whole rush of this SHA shifting, it is because of this 104 billion. That is where the issue is.
When I give you a figure, 104 billion, you might ask yourself, wow, this is a lot of money. But then you do costing of what is it supposed to do, is when you realize it might be less. Because we are supposed to do so much. But we will work within now the budget that we've agreed so that we're able to achieve much. So in terms of the scope, we believe there's value for money.
Lakini sasa Safaricom wameipa kampuni nyingine ya Kenya kazi hiyo.
Why did we pick Safaricom? Because of the wide network, and Safaricom being a national, one of listed companies that has shown that they are able to deliver where technology is required. Now, Safaricom cannot do everything alone. They have partners. They have to bring in consortium members. So we could not put a lot of, say, micro, I can call it micro or mini, right? We had to have, say, this is the scope.
Lipo suala la mimba za mapema. Je, vijana hao watapataje huduma hitajika?
As a ministry, we came up with a policy to guide that. And we have guided Social Health Authority to allow now registration as a teenage mother. And then they are, because they are now in the Linda Mama program, so it's not a big challenge to us. They will pay for them as teenage mothers. So we've opened that. The fact that they have gone to the facility for antenatal, they are able to be identified.
Matabibu wamesalia wakigoma kila Jumatatu kufuatia kile wanachosema ni ubaguzi.
We have more than 1,000 facilities that have been registered by the Clinical Officers Council. We have over 5,000 specialized clinical officers. These people, under the NHIF, they were offering services to Kenyans. But now the SHA board has decided only those registered by the KMPDC can be registered and contracted or can do pre-authorization.
Clinical officer, including specialist clinical officer, are now forced to go through an individual who are registered under the KMPDC.
I'm not saying the challenge between SHA and the Clinical Officers Council and unions. We say we are streamlining the healthcare system. We are reorganizing the healthcare system. We looked at how do we onboard facilities. First step, we said, okay, fine. The regulator that has a wider mandate is the Kenya Medical and Dentist Practitioners Council, which is supposed to inspect every facility and license and categorize that license, that facility. It is KMPDC. We don't deny what the provisions of the Clinical Council, the Council Act also says in terms of who is the Clinical Council, what Clinical Council can do. We're not refusing. It is there, it is provided for in the law. They can license you as a clinical officer, that's a requirement. And also, when you declare that I want to operate from here, they can also license that facility or that premise or that room for you to offer that service. That's okay. But the wider mandate goes back to the KMPDC. Mark you, even before, it was the NHIF who were visiting these places. They have licensed the place, but NHIF will again visit and go and file a report and panel and then come on contract before. So we said, okay, no, it can't be like this. Let's give it the regulators. So we want to make sure that when we do an audit trail, who did what? We have had cases where we have lost patients just because of negligence here, negligence there, who did what. The problem is, they They said, no, why you are favoring doctor? We are not favoring anybody.
Helen